We've seen some clinical reports in the past few weeks with TMB in large phase 3 trials. For instance, the chemo plus pembro studies, which were the Keynote 189 and the Keynote 21G studies, they went back and looked at tumor tissue, they sequenced them, and they felt that if the tumors had a threshold of 175 mutations higher than that or lower, to see if there is a differential effect of the chemo plus pembro regimen. And both of these studies showed no difference in outcomes for the chemo plus pembro as a function of TMB. So in that experience, TMB was not a useful biomarker. But at this meeting, we heard very different data when you're talking about pembro alone as monotherapy. What can you tell us about these results, Johan?
Well, it seems like when you use chemotherapy plus immunotherapy, you fade out quite a lot of the biomarker data. And that is the case for PD-L1 as well. The chemo plus immune is superior to chemotherapy alone in all PD-L1 subsets with some variation according to expression. It's the same, we have seen the same for chemo plus immuno with tumor mutation burden. Strange enough, with pembrolizumab alone, which can be administered either in patients above 50% tumor proportion score, which is what we do in Europe, which can be also be administered in patients above 1%, which is currently coming practice in the US. So in that setting, tumor mutation burden seems to add extra value to the prediction of a better outcome of the patients. So if you give pembrolizumab alone, and I think we didn't see these data, and it was unfortunate that we didn't see them, but what I would like to know especially is in the group with PD-L1 between 1 and 49%, if TMB adds their extra value. What was reported, it adds extra value slightly if you're above 50, it adds extra value if you're above 1, but what I want to know is what does it add in those who have a PD-L1 between 1 and 49%, and we didn't see that yet. But certainly there seems to be a complementary role there.
And the pembro monotherapy data with TMB being a predictive marker aligns with the NIVO data that was presented a couple of years ago in the New England Journal, where high TMB was correlated with NIVO therapy efficacy compared to chemotherapy. Now, as we talk about PD-L1, TMB, it's hard not to discuss the Empower 110 study that was presented at the ESMO Congress. Atezo versus platinum-based doublet chemotherapy. This was presented by Dr. David Spiegel. Now, we know that the pembro versus chemo experience resulted in favorable outcomes for pembro. Nivo versus chemo did not. And in the MYSTIC trial, durva versus chemo did not result in improved survival. Talk about what you took away from the Empower 110 report, Johan.
So Empower 110 was the atezolizumab study comparing single agent atezolizumab versus chemotherapy. And so what was seen there is that the effect was in terms of outcome, and it was an early interim analysis. It was not the final interim. It was not the final overall survival analysis. It was an interim overall survival analysis. And what came out is that the tumors that had a tumor or immune cell score, immunohistochemistry score of 3, that there was a significant overall survival benefit when atezolizumab was added to chemotherapy. For those who were who had an immunohistochemistry of 2 and 3, it was borderline, and further follow-up is needed. And in those who had an immunohistochemistry of 1, 2, or 3, that has not been analyzed yet because the 2 was all. But again, in that data set as well, what we would like to see is how do they behave as category 3, category 2, and category 1 separately, because they always fuse 3 and then 2 and 3 and then 1 and 2 and 3, which means in the lower categories you always have a carryover of the best effect, which makes it difficult to interpret the data. And so gradually I think they will come, but we don't have them yet. But the message at the present time is atezolizumab single agent was a valid option in patients that have a TC or IC3 scoring on their biomarker.
So how commonly do people in the United States possibly test for TC3, IC3 for a diagnostic workup?
I think it's the exception rather than the rule. I think most reports, either from our own pathologist or from commercial vendors, is just the PD-L1 tumor proportion score. I don't think that there's a separate testing for immune cells versus tumor cells. Now, maybe with the data that we have today in the frontline setting with atezolizumab, that will change, assuming there's a regulatory approval in that setting. So we'll see if that practice changes.
Sure.
We rarely test immune cell in tumor specimen. We usually look at the PD-L1 expression in the tumor cell by doing SP263 and 2263 assay. So it's really hard to see immune cell staining of PD-L1 in the tumor specimen. It's a laborious.
Pathologists don't like it. It's
right.
a very challenging thing.
And also, I think the other thing is that it would be nice to know, is the benefit the same in the TC3 and the IC3, or are they separate populations? Are they the same population, right? So I think that's degree of nuance we haven't quite yet seen either.
So fortunately, this data will be reanalyzed using the 22C3 and the SP263. So that will give part of an answer to that question.
Yeah, so that'll give you some harmonization as well if most pathology practices already use the antibodies, those other antibodies.